So it's my pleasure to introduce Professor Galle, Peter Galle, Clinic Director in Mainz, who is someone who is very well known in the field of hepatocellular carcinoma. He provided important insights. It's always good to have discussions with him. He has a very critical mind about the results, and he's also the chair of the guidelines of hepatocellular carcinoma from the EASL. So, Peter, thank you very much for agreeing to cover these important aspects, which is how to prevent hepatocellular carcinoma recurrence after curative therapy. Thank you.
Thank you very much, Jean-Francois. It's a pleasure to be part of this esteemed faculty, an honor. Happy to be here and to extend the systemic therapy from advanced stage disease to earlier stages, because this is precisely what your question, which you posed on me, how to prevent HCC recurrence after curative therapy means. We do have a situation where we can offer by ablation, by resection, and by transplantation therapy in curative intent, but in clinical reality, we are well aware that the recurrence rate is high, sometimes extremely high. You can perform clinical risk scores and then define clinical situation where after resection recurrence is almost obligatory, and indeed then you will find patients where after 5 years almost 70% have shown recurrence, and that clearly defines a need for additional neoadjuvant, adjuvant or perioperative therapy, and we can discuss what is optimal, and Richard was already pointing into that direction. But at present, we have to admit there's nothing approved. It's an unmet medical need. Theoretically, it has been modeled. We assume that a tumor resected may recur. At the same time, the inherent risk of the underlying liver disease persists and stimulates de novo tumors. It has been suggested that the first 2 years are basically coming from true recurrence and later onset de novo tumors. So in the end, you may argue you can, by additional systemic treatment, either take care of residual disease, minor tumor burden, or chemo prevention in terms of the interference with de novo tumors, or both. And that is the question of today. We have, and it's again surprising to have these data been published more than 15 years ago, indeed parameters, also genetic signatures coming from not just the tumor, but from the liver, from the cirrhotic liver, predicting recurrence. So we have means to estimate the risk of tumor progression, of tumor recurrence in the future. But it's, as Richard was already pointing out, with respect to systemic therapy in general, unfortunately, nothing which really had made it into everyday life. This is not bread and butter. This is still academic. Nevertheless, high recurrence stimulated with the onset of systemic therapy, the idea to use this systemic therapy not just to treat advanced stage disease, but to take it as an adjuvant treatment after curative intent treatment with resection or ablation to reduce recurrence-free survival. Unfortunately, the initial trial, the STORM trial, where sorafenib was compared with placebo, was a clearly negative trial. You see that recurrence-free is basically the same for sorafenib or placebo. But there were some interesting differences. The first comes from the duration of treatment. Sorafenib was sorafenib treatment was much shorter compared to placebo, and that can well be explained by a higher rate of adverse events, not surprising, and consent withdrawn is probably the same as adverse event. And conversely, the disease recurrence was more common in placebo. You may take that as an indirect argument that there might have been some activity which, however, was spoiled by toxicity, and this is always a true aspect of liver cancer treatment. Be aware of toxicity. In the end, these data, basically coming from STORM and some small other trials, have stimulated our guidelines in 2018 to definitely not recommend any neoadjuvant or adjuvant treatment because evidence is lacking. However, in the days of immune therapy, it's very tempting to switch gears and to re-challenge these initially negative TKI data with current immunotherapy. And in fact, it's interesting to see that this is not just a new story, it's actually a relatively old story. You see here a Lancet paper from 2000, where adoptive immune therapy was installed using autologous lymphocytes activated with IL-2 and antibodies to CD3, and compared to no adjuvant therapy. And the numbers were actually quite impressive, 150 altogether. And it was shown that immunotherapy indeed was able, at a statistically significant level, to reduce recurrence-free survival. A similar paper, a bit more recently, used autologous cytokine-induced killer cells, and again showed not just in terms of recurrence-free survival, but also in terms of overall survival, a benefit for this cell-based therapy in an adjuvant setting. So I think there are, although sketchy, but there are data which create hope that immune therapy would work, and that has, of course, stimulated the armamentarium of available therapy, which has been proven to be effective in an advanced stage, to be tested in adjuvant setting. So basically, the story is always the same. Therapy in curative intent, either resection, this is for the most part, for the majority of the patient the case, or in some patients ablation with complete response, and then a treatment arm or placebo or surveillance and checking for recurrence. Several trials are on the way, and last year we already saw first data from IMbrave 050. IMbrave 050 was using atezolizumab bevacizumab, randomized 1-to-1 after curative resection, R0 on pathology report, or ablation with complete response by imaging. That trial was allowing, and that was the case in about 10% for, I would say, Asian specialty, and that is adjuvantase. Not sure what that is, but it was happening in 10 patients. That delayed, in some cases, the systemic treatment. It was allowed to get started between 4 and 12 weeks with atezo beva, tested primary endpoint for recurrence free survival, and in the secondary appointment assessment for OS. This trial was selecting for high-risk patients, and this selection took into account the number of tumors, the size of the tumors, vascular involvement at the level of VP1 and 2, and also tumor grade differentiation. That is, I would say, a selected subgroup, but of course will keep the time required to perform such a trial shorter. It's a hierarchical testing, starting with independent review assessed recurrence-free survival, and then going for OS. Here we just have seen the interim analysis. It was a basically Asian trial, and the prevalence of Asian patients in the end also defined a high prevalence of hepatitis B underlying etiology. And not surprisingly, most of these patients were early stage patients. That is where we can resection or ablation apply in curative intent. Most of these patients in the end indeed got resected, 87%, only 12% ablated. Most patients had single tumors, resected 90%, in the ablated 70%. And here you see the median range between 1 centimeter and 18 centimeter, and median of 5 for those resected. And quite a significant proportion showed indeed this high-risk profile of microvascular invasion, some even macrovascular invasion, and 40% were poorly differentiated. The trial is a positive trial and showed, if you take the landmark at 1 year, a reduction in comparison between atezo-bev treated patients. 78% remained recurrence-free compared to 65, so 13% less. And this is after 1 year. It's an early trial. You see that in the right-hand side of the curve, not a lot of patients are there. And what is a bit disturbing is that these curves merge in the end, and that opens the door for the question, is it really interfering with recurrence, or is it just a minor delay of recurrence, which would be of little clinical benefit? This is something where this trial is just too early. At this time, we don't know. There was no difference in the end between investigator assessed or recurrence-free survival and independent review, and there was a clearly statistically significant hazard ratio in favor of the combination. Excuse me. With respect to subgroup analysis, there is a rather homogeneous response. Patients who received TACE, as I said, just about 10%. Patients with smaller tumors and patients with a poorer performance status might not have responded as well, but this is basically just hypothesis generating these subgroup analysis. It's fair to say that most patients apparently benefited. What will be a problem in the future is that what we would love to see an impact on OS is in a setting where crossover is allowed, and actually in blue taking place in most patients under surveillance who show recurrence, they switch, and that probably will make the evaluation of overall survival very difficult. At this first interim analysis of OS, only 7% event patient ratio was achieved, so this is not meaningful at present and basically open. There were, that should be mentioned, some fatalities, grade 5 adverse events, 6 in the atezo-bev and 1 in the active surveillance arm, and that was also considered to be treatment related in 2 cases with varices bleeding and 1 ischemic stroke. That remains to be seen. I mean, this is always a concern in an adjuvant setting. You don't want to have too much toxicity. It's a positive trial, and it's the first adjuvant trial ever showing a positive result. This, I think, is a step forward. Safety profile consistent, OS not mature, and the question whether this is practice changing or not is, I think, to be decided in the future. This trial has been published in Lancet, and it was pointed out in the summary that we need a more mature data set before we can finally conclude on that. Richard Finn was already pointing out, excuse me, that neoadjuvant setting compared to adjuvant is not just a different time point, it's a different setting because you are treating an existing tumor in an existing tumor environment. And he pointed out to this positive trial where there was in melanoma a difference shown. And it makes theoretically a lot of sense to go into the existing tumor microenvironment and stimulate the tumor infiltrating lymphocytes instead of taking them out and treat afterwards. That can theoretically, in a situation where upfront resection is an option, reduce recurrence. And of course, in those patients where initial inoperability has been diagnosed, that might convert patients under neoadjuvant therapy into liver resection. And the same setting applies also for the transplant setting. You may get started with patients by definition being good transplant candidates and do just bridging for liver transplantation. But of course, you might be able to downsize patients into Milan and allow liver transplantation upfront not possible. So that's the scenario. Although the evidence level is relatively low, it was very clearly recommended by the EASL guidelines that in liver transplant candidates, local regional therapies should be applied. It was not specified. For the most part, this is typically TACE, but it can be SEERD and other therapies, including ablation as well. Most of us believe that it's actually not the impact of the therapeutic intervention on the tumor, which then results in a good outcome. It's probably rather the reaction of the tumor to this therapy, defining biologically defined benign tumors or more aggressive tumors. Because if you are able to control using TACE a tumor, it tells us this is a tumor which is not so aggressive, probably a good transplant candidate. It has been in smaller and retrospective and single-center trials demonstrated that that can actually be extended to intermediate stage therapy. If you do neoadjuvant therapy in intermediate stage, there have been data demonstrating that there is no difference between early stage and intermediate stage disease. And in particular, and that again comes to the definition of what is the biology of the tumor, if there is a response, so it's always worth trying and always have transplantation in your mind. If there is a good response, and in particular complete response, outcome is excellent, even if it initially was outside the early stage. There are quite a few trials investigating immunotherapy in a early phase situation. Here, a trial using semiplimab, which is a PD-1 antibody, in patients in a neoadjuvant setting, 20 patients, and demonstrating that there is a significant proportion in this setting, 40%, which reached a predefined necrosis threshold of more than 70%. If you take a threshold of 50%, then you can nicely separate these patients genetically based on their individual signature in those where necrosis occurs or not. That's the beauty of neoadjuvant treatment. You typically treat a tumor, which you then take out, and you can then analyze the tumor and learn. So that is a major advantage why neoadjuvant treatment is helpful. And this is the same stimulus which in the end resulted in this PRIME HCC trial here using ipilimumab and nivolumab, one dose of ipi and 2 cycles of nivo followed, and then liver resection. And then you have lots of material to play with and to define responders and non-responders. And you might even use neoadjuvant treatment here using cabozantinib and nivolumab, and also in, again, a relatively small group of patients. But these patients were initially considered to be no surgical candidates and were converted into a situation where resection was possible with, in the end, a good outcome. So there's a lot going on. And if you think about it, in GI cancers, neoadjuvant and adjuvant perioperative settings with immunotherapy are quite common. So I would be optimistic that this is the case for liver cancer patients as well. In the end, the situation is getting more and more complex, and this is why we should always sit together, bring all our expertise in, never forget about the transplant option. And in the setting of neoadjuvant and adjuvant therapy, I'm quite optimistic that we are seeing major advances in a relatively near future. Thank you very much for having me and for your kind attention.
Thank you very much, Peter, really, for bringing these trials also moving before the treatment with immuno-oncology. I think this is we are learning from other fields, and we are getting there. Do we have any questions? Anya?
Thank you. This is Anja Lachenmeier from Bern. I have a question. You showed very nicely how the cirrhotic gene signature can predict the recurrence of the tumors. Do we have any information on how the systemic treatment might change this gene signature in the cirrhosis?
No, we don't. But again, this would be a wonderful way to use resected material from patients after neoadjuvant treatment, because then you would be able not just to concentrate on the tumor, which mostly is the case, but also on the tumor environment. And this inherent risk of the cirrhotic liver is certainly something which requires attention, but good point.
Using the immuno-oncology before treatment, do you think the treatment, is moving the camera, okay. Before the treatment itself is probably relevant. If you do that before surgery, if you do that before ablation, if you do that before radiotherapy, if you do that before TACE, do you think you will get the same, you release plenty of antigen when you do these, some of these treatments, particularly with radiotherapy. When you do the resection, you just remove it. There is no more antigen being released during the surgery. So you expose the tumor to immuno-oncology before, you will still expose also the patients without the tumor to some immuno-oncology after. So you think that we should pay attention to the kind of treatment, curative treatment we are giving to these patients?
I think that the maintained tumor microenvironment, so an interaction between tumor cells and defined subsets of T cells and other cells is probably more likely upon stimulation with immunomodulatory agents to foster a general anti-tumor immune response compared to a situation where the tumor has been taken out. And I mean, just quantitatively, you are taking out infiltrating the lymphocytes. And we know that the presence of the pre-existing presence of lymphocytes is mandatory in order to have a successful immune response. Whether this is modulated then by modes other than resection, such as ablation, SIRT, TACE, that definitely needs to be investigated. But as you said, Jean-François, I think it's very likely that shedding of tumor antigens, this sort of internal vaccination, as we might consider it, is probably helpful.
Yeah, internal vaccination. I like this one. I just check if we have some questions online. Give me a second.
It's already late.
No, we are right on time. Thank you. No, we don't. But thank you very much, Peter, for this presentation. We really enjoyed it, and thank you for being with us today. Thank you very much, Peter. Have a good afternoon.
Thanks for having me. Bye-bye.